The next speaker I would want to introduce is Reuben. Reuben's in Stockholm at the moment. And he is just going to tell you a little bit about his research and findings. So, Reuben, I'm leaving it to you. Take it away.
Thank you, Theo. Good afternoon, everyone, and I hope you're enjoying the conference. My name is Reuben Mugisha. I'm a PhD student at KTH, Royal Institute of Technology. I'm originally from Rwanda, and I also dabble as a co-founder of a company in Rwanda called LMICs, which does professional training in different key areas that are required for the development of Rwanda, and I'm looking at different fields. So I wouldn't say that I'm focused on healthcare or technology or whatever. So we see where there's need, and then we get experts from the West, and then we work with the local community. That said, I will start with my presentation on building an all-inclusive digital health in low and middle-income countries. By the way, my PhD thesis is on enablement and sustainability of digital health in low and middle-income countries. So by inclusive, I'm looking at accessibility, the digital health that is accessible to everyone, especially the persons living with disabilities, and also the people not to be excluded because of the way they are created. User-centered, to be focused on the users, to be able to see that users will be able to use it. We'll go into details on that. Inclusivity, same, multilingual support, to be able to use digital health in a language that is known to the user. Then compatibility, we'll look at it, and other synonyms and antonyms, and then privacy and security, which is a hot topic today, and then scalability, to be able to scale it to other places, and we'll look at that in details later. Some key statistics on digital health readiness in low and middle income countries. Looking at mobile health first, according to the World Bank, mobile phone penetration in the low and middle income countries reached 84% in 2019, up from 53% in 2010. That's according to the World Bank. This has enabled the rapid growth of mobile health solutions in these countries. A study published in the Journal of Medical Internet Research found that mobile health interventions have been implemented in 83 low and middle income countries as of 2020. Let's look at internet penetration. According to the International Telecommunications Union, ITU, internet penetration in low and middle income countries reached 20% in 2019, up from 8% in 2010. Access to the internet is still limited, though, in many rural areas and among low and middle income populations. Coming from Rwanda, I would like to also hint on a few information about Rwanda with regard to internet and mobile penetration. Mobile internet is the primary means of accessing the internet in Rwanda, with 56.6% of the population using mobile internet as of January 2021. The Rwanda government has made digital inclusion a priority, with initiatives such as the Smart Rwanda Master Plan, which aims to transform Rwanda into a knowledge-based economy. An increase of internet infrastructure has contributed to the growth of internet access in Rwanda. In 2019, the African Development Bank approved $266 million loan to support the expansion of broadband infrastructure in Rwanda. And with that, there's a lot of projects going on in building the infrastructure and making it ready. As of January 2021, internet penetration in Rwanda was 16.5%, representing an increase from 4% in 2010. So now, digital health. The COVID-19 pandemic has accelerated the adoption of digital health solutions in low and middle income countries. According to a report by the World Health Organization, more than 80% of countries have adopted digital health, specifically teleconsultation to some extent during and after the pandemic. The readiness in low and middle income countries, it is expected that the growth of digital health solutions will continue in the coming years as technology becomes more accessible and affordable. According to the report by Frost and Sullivan, the digital health market in low and middle countries is expected to grow at a compound annual growth rate of 21.4% between 2019 and 2025. Regulatory frameworks. The African Union has launched a digital transformation strategy for Africa, which includes a focus on digital health and the development of regulatory frameworks to support it. There is a growing recognition of the need for regulatory framework to support the adoption and implementation of digital health solutions. Here's the challenge. Despite the growth of digital health in low and middle income countries, there is still significant challenges to adoption and implementation, including limited infrastructure, funding, standardization, and regulatory frameworks. The solution, it will be important for governments, healthcare providers, and the technology companies to work together to address these challenges and ensure that digital health solutions are accessible and equitable. Let's look at accessibility. Ensure that the technology is accessible to everyone, regardless of their abilities. Most tools used by persons living with disabilities are not digitized or connected. Design should consider people with disabilities such as visual, hearing, or mobility impairments. While conducting a study at Gahini, we found out that there is no health information system that collect the information for the persons with disabilities. Secondly, we also noticed that all the equipment that they use are non-digital. There is no way information can move from the person with disabilities to the national database. These tools are created for the people that are normal. So the inclusion of information about persons with disabilities is still limited in most countries. So for an inclusion of digital health, accessibility should be at the top of the agenda. And studies should consider different disabilities and try to address their needs while developing digital systems. Most digital systems are not user-centered. The designers design these tools and avail them to the governments. So focusing on the needs of the users and the design technology that is intuitive and easy to use is a key component that would increase the all-inclusive digital health use. They should be conduct research, gathering feedback, and testing the technology to see that it suits diverse groups of users. This is still a challenge because the low and middle income countries lack resources to conduct these studies and to do the testing. Therefore, for an all-inclusive user, there has to be investment in working directly with the prospective users of these systems. Inclusivity. Ensuring that the technology is inclusive of all users regardless of the race, ethnicity, gender, sexual orientation, religion, or other characteristics. While conducting a study in Zambia on the use of digital tools for screening cervical cancer, we found that these tools cannot be generalized as tools that can be used for screening by any clinician to these women. The women had phobia that they cannot be screened by male, for example, people of opposite gender. Secondly, also the elder groups of women were not into the idea, buying into the idea of being screened by even younger girls who are clinicians. So there is sensitivity when developing these tools. So for an inclusive digital health system, there has to be considerations of these issues. We should avoid bias in the design and development process and ensure that the technology does not perpetuate stereotypes or discrimination. So issues of ethics, accessibility, and culture still stand as key to the implementation of an inclusive digital health. Language, multilingual, or adoption to the cultural language that users, or the perceived users, will use. We should provide support for multiple languages to ensure that users can access the technology in their preferred language. Compatibility. There are issues of compatibility, de facto standard, and interoperability. Digital health tools should ensure that technology is compatible, of de facto standard, and interoperable. For example, many digital equipment that is used in the low and middle income countries is donated. And the biggest challenges that we found while interviewing the clinicians who use these technologies were that some of this equipment does not have its consumables on the local market. Some of the equipment is stored, is already kept, cannot be used because it's non-functional. Therefore, the issue of de facto standard is of paramount importance. Interoperability is also another aspect. Some of the systems do not accept other systems that are being implemented, that are being rolled out in these low and middle income countries. It is therefore important that the systems that are the digital health systems that are recommended are interoperable to other local and existing systems and compatible even with the software that they use. Security. Data security comprising of confidentiality of users, integrity, and availability are very, very important components in ensuring an all-inclusive digital health. Scalable and sociality. I'll combine these two. Implementation of digital health tools should ensure that the technology is scalable and sociable to accommodate a growing user base or changing user needs. For example, how most private people will use it, how the public will use it, and smaller groups and big groups. But scalable also, we're talking about how it can be scaled from the urban centers to the more consider differences in the infrastructure growth, the level of connectivity, the offline and the online, real-time store and forward, all those. Let us also see another component that is important in an all-inclusive. We should also consider that sustaining digital health is important because it is of no use to have digital health rolled out and not able to sustain it. So there has to be developing robust digital health infrastructure such as a national health information system that include electronic medical records, digital health and mobile health applications is important. Exploring innovative financing mechanisms such as public-private partnerships, performance-based financing, and social health insurance schemes is very, very important. developing regulatory frameworks that are adapted to the local context and promoting collaboration between stakeholders, including governments, private sector, and civil society organizations is important. Developing training and education on digital health concepts, promoting digital literacy, and supporting the development of local digital health expertise is important. So with that short presentation, I would like to stop here, and I would like to welcome questions, if any. Thank you.
Hi, Reuben. Thank you for that. Yeah, let's just leave the floor open for a bit because we're a little bit ahead of time or behind time. If there's any questions, please just pop it in there. Okay, thank you. Just a question on my side. Was this study only conducted in Rwanda?
The study was conducted in Rwanda, in Uganda, in Burundi, and Zambia.
Okay.
So I couldn't present everything, so I picked a few and generalized.
Okay. And with the app designs, is it sort of done within the local country itself, or is it sort of done externally and then try and implement it within the country?
The study was done physically in these countries.
Okay.
Not remotely.
We just had a question here from Patricia. I don't know whether you'd be able to help with this one. She says, could you go through a specific example of digital implementation from urban to rural areas and some of the challenges?
An example would include a system called TrackNet in Rwanda. This is a mobile-based system which uses interactive voice response. They call it IVR. You may recall that when you dial some of the numbers anywhere, like you're calling a telecom company or you're making booking a medical appointment, there is a voice that says place 1 to cancel, for an operator, place 2 for this and that. That is called IVR. It's a recorded voice that's stored somewhere in the system. So TrackNet system used a toll-free number, and it was for nurses to report on the status of patients, but also to report on the scarcity of some of the consumables about HIV and AIDS patients. So because the mobile penetration in Rwanda is high, this system could be used in the local communities that don't have internet because they have mobile phones. They can just use a simple phone that doesn't have even a screen, that's not smart. Let me use that word. And you just place 345, welcome to TrackNet. What kind of patient are you reporting? This and which information would you like to report about? So each center had its own unique number, and they were able to actually update the Ministry of Health, and the Ministry of Health remained updated about what is going on at all the healthcare facilities. Now, in the urban places like in Kigali, they used a web-based system because there was no need to use the mobile phones because everywhere there is internet in the urban settings. So that is one example that comes to my mind that I can brief you about.
Yeah, Patricia says, great example. Thanks for sharing. We have another question from Jesmond. What did you say the biggest design differences between higher income and lower income countries?
Come again?
What did you say is the biggest design differences between higher income and lower income countries?
The design differences, let me use this example. The internet speed is good. in the high-income countries. So you would expect to be able to send an image in a faster time than in the low and middle income settings. In the low and middle income settings, the urban parts are almost the same as in the high income countries because the internet is relatively good. But in the high income countries, everywhere the internet is good. If I went to the northern part of Sweden or the southern part of Sweden or any remote part that is outside of Stockholm or any city, I would have the same internet coverage on my mobile phone and on my tablet. But I wouldn't expect the same experience if I went to Tanzania or Rwanda or Zambia. It's very, very different. So there is a big difference in the rural and urban. And that is the main differentiating factor of the low and middle income countries and the high income countries when it comes to internet penetration and use of digital devices. So I would be assured that a patient in the remote part of Sweden will be able to discuss with his clinician who is based in Stockholm easily than a patient who is in the remote parts of Rwanda discussing with his clinician or her clinician in Kigali.
Okay. Thank you for that. I don't think we have any more questions, Reuben. Really appreciate it. And if there's anybody that has any other questions, please, they can reach out to Reuben, whether it being through your LinkedIn profile or just contact me and I'll share his information. But yeah, thank you so much. And also just to sort of complete your talk, is that also, I'm in South Africa and in our rural parts, people have very little access to smartphones. So they're using these feature phones, so everything has to be done, I think it's called SSID, using these feature phones, not the access to smartphones. I'm sure, I don't know if it's the same in Rwanda, but in Africa or in South Africa, we have that problem.
On that, I can add that use of digital health that does not necessarily require that you have these tools physically. You could also use it as store and forward. You could have everything on a storage device, and then you can take it to the clinician. For example, the health center can take some images about patient or some patient information and can pass it on to somebody who will transport it safely and securely to a clinician for diagnosis of the patients. So store and forward is another alternative. What I can say is that having all these tools and connectivity in very good connectivity is not the only determining factor of the use of digital health. Digital health can be used, but then, of course, not in the same way as in when you have all these tools available and in good working order.
Okay. Thank you so much. We'll head over to our next session. We're about 12 minutes behind. So we will see everybody there. Thank you so much, Reuben. Have a lovely day.
Have a good one. Thank you.
Bye-bye.